Well, welcome back. Yeah, I'll just call you up as we go. So good afternoon. I hope everybody had a nice little stroll through the exhibits and met some of the amazing engineers and technicians developing all these new treatments and cures. I think you know by now I'm Mike Crosby. I'm the founder of Veterans Prostate Cancer Awareness in the United States and 3 times prostate cancer survivor. So I'm proof that PSMA and nuclear medicine can keep you alive. I will tell you also that of my 3 recurrences, my course of care has changed dramatically after each one of those images. And I'm happy to talk about how that affected things or what they found on all those. But the standard of care versus my path or my journey is much different because of this technology. So that's why I'm a huge supporter and always will be. So we're going to get together here. We've got a lot to cover this afternoon. I guarantee you're going to learn something from all these 4 speakers. And but also, please, I think there's microphones floating around, and when we get to the question points, jot your questions down, and then and at the end of their talk, we'll have a question and answer. So first, though, I want to introduce, in the medical world, a very famous individual, Dr. Lawrence Klotz. Dr. Klotz is the chief urologist at Sunnybrook Health Sciences Center in Toronto. He's also a professor in the Department of Surgery at the University of Toronto. And he also serves as the chair of Canadian Urology Group and is the founding editor-in-chief of the Canadian Journal of Urology. So I'd like to welcome Dr. Klotz, and here he is.
Thank you, ladies and gentlemen. And I have to say, I'm impressed that at your commitment to learning, coming to a nuclear medicine conference as a patient or patient advocate is really showing some serious commitment. And we've changed the order. Let me see if I can get my slide up there. You can bring up my slides. I missed that one. I don't know, it's a different slide set. We can come back to it.
Yeah, there's a picture of you.
So we've changed the order from what was originally planned because kind of the usual progression is localized to locally advanced or recurrent to metastatic to castrate resistant. And they had it kind of set up the opposite way. So we're going to do that order, and I have the privilege of going first. This is the urologist perspective. To be honest, I really wasn't sure, like, what are these people looking for? And how informed are they? And I'm still not 100% sure, but I'm giving you, this is kind of what I took as my frame of reference. What is this from my perspective, PSMA? So just how many of you are local? Okay, so maybe half. So I don't know if you know the situation in Ontario as far as PSMA. Let me just ask, does everyone here know what PSMA is? So that is not part of my talk. And I have a feeling we have a nuclear medicine specialist here who's the last speaker, and I suspect he's going to cover that. But PSMA stands for PSMA. Prostate-specific membrane antigen. So the M there is very important. It's not PSA. PSA is a circulating antigen that's secreted into the serum, and you can measure it in the serum. It acts as a screening test for prostate cancer. That I'm sure you know. PSMA is a non-circulating. It's expressed on the surface of prostate cells, and therefore you can detect it, and the whole basis for the PSMA scans is a specific ligand, meaning a molecule that attaches to the surface membrane antigen. And that, the term is ligand, meaning a molecule that attaches to another molecule. the ligand is linked to a tracer, which can be gallium or a number of others, and there's a number of different ligands. So there's monoclonal antibodies, there's what's called small molecules that bind specifically to the PSMA antigen, and so you administer this, it binds to the prostate cancer cells, and the radionucleotide gives a signal. That's the basis for it. And there's a whole bunch of nuances to this that I'm not going to talk about, but one of the four of us is going to talk about things like non-prostate cancer cells that may express the antigen so you can get a false positive, the limits of detection. So although it can detect very small amounts of the PSMA or cells that express PSMA, it's not a microscope. So if you may have very tiny amounts of prostate cancer cells that you can rely are not going to get detected by this scan. So there's a lot of, and finally, the part of the complexity is, as I mentioned, there's a slew of ligands, about 6 of them, and a number of different radionucleotide tracers as well. So you get a lot of different combinations. They each have pros and cons. I'm not going to talk about any of that. It's not my area. I'm just a simple urologist. And so I'm going to talk about what this has done in my field. And it's a real game changer. So first of all, in localized disease, this is just a kind of summary of the impact. And a lot of this, my colleagues are going to talk about. I'm really focusing on localized disease. Laser pointer. So first of all, diagnosis. So I'm going to show some data in a second. If you have a positive PSMA and a positive MRI showing disease in the prostate, there's one paper, small numbers, 100% of those patients had significant cancer. And it may be that we're going to do away with biopsy, which men would be more than happy about. We move to doing MRI, PSMA, both positive, boom, treat. We're not there yet, but it's possible that we're going in that direction. Low-risk disease. So one of the things about PSMA is the strength of the signal is a function of how much disease is there. Unlike a lot of scans, for example, typical bone scan, you put the patient on hormonal therapy, the prostate cancer regresses, the scan may normalize. PSMA tends to be more positive as the disease becomes hormone resistant. So what does it mean in someone who has, say, a few microfoci of grade group 1 cancer? We don't treat that. This is the active surveillance concept. But if it's very positive, does that mean maybe there's a higher likelihood that you miss some? There's some data to suggest that. And what about a patient who, say, has grade group 2 cancer? Do you know what grade group 2 means? Yes, no? Okay. This is the grading system for the aggressiveness of cancer based on the microscopic appearance. Goes from 1 to 5. 1 is considered low-grade, indolent, favorable. Mostly we don't treat it. 5 we hardly ever see. It's almost always lethal. So it's a huge range. So grade group 2 is at the kind of favorable end of the spectrum. There's a role there for conservative management, but those patients occasionally metastasize. So if you have a patient who has grade group 2 who would normally be treated, but their PSMA is negative, maybe that's a signal for conservative management. High-risk disease, this is really one of the most confusing aspects of the field right now, and we have a multidisciplinary group. In fact, 2 of the other speakers and myself are all part of the same multidisciplinary group, surgery, radiation, medical oncology. Our rounds have essentially, our weekly rounds have almost a huge proportion of them are focused on this situation where you have a patient with aggressive-looking prostate cancer on the biopsy, and they have PSMA, and it shows, say, 1 lymph node in the pelvis, or 2 lymph nodes. What do? Do you still treat the patient aggressively? Is there still a role for surgery? If you radiate, how extensively? There's no consensus about this, and I think Dr. Loblaw, the radiation oncologist, is probably going to talk about this in more detail. False positive scans. So there's a whole slew of conditions. There's neural tumors, ependymomas, schwannomas that give a very positive signal on PSMA. So you can imagine a situation, you do the biopsy, there's, say, significant prostate cancer, evidence of a recurrence, you do the PSMA PET, and it shows a lesion that may turn out to be something completely unrelated to the prostate cancer. Management of oligomets, let me come back to this because I got a few slides about that. Image-guided surgical resection, so this is coming. You administer the PSMA linked to a fluorescent tracer. So under ultraviolet light, it fluoresces. And then you do your robotic surgery, you put in an ultraviolet light source, you can see the lymph node that's got the cancer in it fluorescing. So this is coming. There's a lot of excitement about this in my field. And a biologic question, are the guys who have lesions only on PSMA PET? So in the olden days, patients, say, would have surgery, their PSA would start to go up. And their conventional imaging, which is bone scan and CT, is negative. We call that PSA-only recurrence. And we know those patients do very well. Most of them live 10 or 15 years, much more common for these guys depending on their age, but most of them die of other causes. It's not that much of a threat. What happens today, you do PSMA PET, you find a solitary metastasis that would not show up on conventional imaging. It's so much more sensitive. So how do you treat those patients? Do you treat them aggressively with early hormone therapy, which we didn't do for biochemical-only recurrence? So there's a whole kind of controversy there. And then kind of the same story. Should we be intervening early? Are we going to overtreat patients? Let me keep going here. So this is the paper that I alluded to earlier from Germany. These guys were gutsy. They took 25 patients, MRI, PSMA, radical prostatectomy, no biopsy. This is like heresy in urology circles. To operate without a biopsy, like shocking. Risk lawsuit. 100% of them, there were 25 cases, had grade group 2. This is clinically significant prostate cancer, meaning the kind that's thought to present a threat. Fortunately for them, 100% of them had significant cancer, so they got away with it. And this paper has really kind of shaken the traditional reliance on biopsy. Now, it's only 25 cases. Other people are now doing this. If the next paper that comes out is 250 cases and they still are overwhelmingly significant, this could really change practice. And this is an example. So we call it PSMA PET CT scan because the PSMA nuclear scan doesn't give a very good anatomic image. It kind of looks like this. And you'll hear later, it's secreted in the kidneys, the urinary tract lights up, the GI tract lights up. So the challenge in reading this is to separate what's kind of normal anatomy that takes up the PSMA. It's excreted into the urine by most of the ligands. So here you see, and then the CT scan is superimposed, so that gives you kind of detailed anatomy. So here you see PSMA localized to the prostate. And this is a summary of the 4 studies that are out there in the active surveillance setting. So my group, and Andrew Loblaw, who's the next speaker, is a partner in that with me, was really kind of recognized as the historic group that started this whole active surveillance initiative. So we have a strong interest in this. We've got 1,500 patients that we're following on active surveillance. And so this story is very interesting. Can PSMA allow you to pick out the bad actors? Because there is still a low but non-zero rate of progression of metastatic disease in these men. So here's just the only thing that counts here is the outcome of these 4 studies. You can see they vary from 30 to 220 patients. So the strength of the PSA signal, which is called the SUV max, can predict the percent of Gleason pattern 4. That's huge. A third had more than one adverse pathology on surgical resection if they had concerning features, picks up MRI occult cancer. So, this is just beginning. Like, we can't do a PSMA PET scan in Ontario. We can't get it for men on surveillance. We can only get it for men who have recurrence or very high-risk disease. So, and you can see these papers are all published pretty much within the last year or so. So this is kind of an emerging area. It's very plausible that a couple years from now, this will be routine. Radio-guided surgery, this is another kind of thing that's just starting to take off. And this gives you an example. So these are images from robotic prostatectomy. So here's a case, they took out the cancer after giving the ligand, which is called IS-002, fluorescent imaging agent, and there the whole thing just lights up dramatically. They take out the prostate, then they turn on the light and they see residual disease left behind. Obviously, when this light goes on that causes fluorescence, you can't see anything else. That's the whole idea. And here's kind of the same idea where, you do the operation. Positive margins are kind of the bane of this surgery. You don't want a positive margin, means the patient's probably going to have a recurrence. So this is a way to detect that before you go home. Very promising. And then the next story is PSMA for PSA recurrence after radical prostatectomy. So you do the surgery. PSA goes to 0 in most cases. In about a third of patients having surgery, you get this phenomenon called PSA recurrence, which I mentioned earlier. It's about 30% of cases, a rise in PSA above 0.2. And the conundrum in these cases, where is the PSA coming from? Is it coming from the prostate as the bed of the prostate, a local recurrence? Or did the patient metastasize prior to surgery and you're just starting to see it now? That's the dilemma, because if it's local, you can zap it with radiation. I'm sure Dr. Loblaw is going to talk about that. And in most cases, it goes away. If it's distant, you're exposing the patient to the side effects of radiation, which can be considerable, and with no benefit. So the PSMA has been huge here. Here's the dilemma. We know if the patient's going to get the salvage radiation, the earlier the better. The closer to a PSA of 0.2, which is kind of when we first acknowledge that they got PSA failure, the closer to that point they get the radiation, the greater the likelihood of success. But the PSMA is only positive usually when the PSA reaches 0.4. That's getting too late to give the radiation. So we grappled with this. I'll be interested to hear what Andrew says, but we made a decision, drop the PSMA. We don't want to wait for it to hit 0.4 to do it. We want to give the radiation before. But we don't want to do PSMAs, which can give a false negative signal if you do it too soon. So that's been our strategy for most patients. You can identify high-risk patients. It's a different story. I'm talking about kind of the average patient who takes several years to recur. And then you have the patient who's had the surgery and radiation, or he's had the radiation and then has a subsequent rise in PSA. And the second PSA recurrence, in other words. So as I mentioned, these tend to be indolent, slow cases, 10 to 15 years before this really becomes lethal. The major cause of death is other causes in most patients, although not all. It's about 2/3 die of other causes, 1/3 die of prostate cancer. And so, the PSMA is very helpful in that setting, trying to identify the source of recurrence and treat it. The conundrum that we're dealing with is that there's emerging data that these guys where the conventional imaging is negative, but the PSMA PET only is positive have actually, they really look like these guys with late, slow, indolent recurrence, not that much at risk. And how to manage these patients is really, at this point in history, is a very tough problem. We don't have randomized data on the survival benefit of this early treatment. And if you find a solitary metastasis, you treat it with radiation, for example. Does that actually prolong the survival? We don't know. It does prolong the time to recurrence. I mentioned, and then sometimes you see a solitary lymph node on PSMA in that setting. So another thing that's emerging, again, this was published, I think, like 2 months ago, radio-guided lymph node dissection. So you have your robotic instruments in there, you turn on the fluorescent light, you see the lymph node that has the tumor in it, and that's the one you resect. I mean, this can be really enormously helpful. I don't think a single case of this has been done in Canada yet, but it's happening in a number of centers and it's coming. Just one kind of radiogenomic slide. I mentioned the evidence. This compares the genetic alterations in PSMA-only oligometastasis. OM is oligometastasis, meaning few number of metastases, versus conventional. So these look worse. I mean, in other words, more mutations, more pathogenic alterations with conventional imaging. These tend to be larger, more advanced, but even corrected or adjusted to that they're comparable in terms of volume. And here you can see overall survival, much better for the PSMA only. So fewer mutations, better survival. We don't want to go crazy treating these patients with interventions that are going to adversely affect their quality of life. They don't really need it. And then finally, and then I'm just wrapping up, this just shows the benefit of PSMA compared to MRI. So they're complementary, but here's a case where they both show the same thing. So this is a lesion on the MRI. This is called T2 weighted image, and cancer looks dark, and there it is on PSMA. So everybody's happy. Another one where you have lesion on MRI that corresponds to the lesion on PSMA, but then you get discordance. So here's the MRI that shows a lesion here. Depending on which parameter you use with MRI, it can either be bright or dark. Cancer can be bright or dark. But so these are 3 different cases. Here's MRI, here's PSMA. 1, 2, 3. Same story here, same story here. So more disease seen on PSMA. So, it increasingly looks like, and this is a case of granulomatous prostatitis, whose MRI looked terrible. Granulomatous prostatitis, which is a kind of subset of chronic inflammation in the prostate, can really mimic prostate cancer on MRI, but not on PSMA. So this was MRI positive, PSMA negative, could have avoided biopsy. And then this one is a scary case because we rely on MRI tremendously. This guy had grade group 5, the worst kind of prostate cancer, and his MRI was negative and his PSMA was strongly positive. So just to make the point that PSMA can really complement the other imaging. Another similar one. So bottom line, this is my last slide. It's more sensitive for detection of metastatic disease. It's going to clearly play a role risk stratifying localized disease. But we're in a state of, it's like that line, I'm still confused, but at a higher level. So we are confused at a higher level because we don't know what to do with many of these situations where we find this disease that's much earlier than we used to diagnose it. And does it really pose the same implications for the patient's survival and long-term outcome compared to conventional imaging? Thank you very much.
Any question for Dr. Klotz?
Yes.
Do I need a microphone?
No.
You can talk loud enough.
Okay. So, in terms of treat or not to treat, if it's a man with a pathogenic BRCA2 mutation, you factor that in, or just say, don't worry about it, I'm going to look at the imaging to go forward?
Well, it depends which. The question was a germline mutation is what you're asking about. So this is about 5% of patients with localized prostate cancer will have a defect in one of the genes or a mutation that codes for DNA repair. So it corrects for the mistakes that are made in gene replication, and we know those are more aggressive cancers. So the short answer is it's got nothing to do with the PSMA. If it's a BRCA2, which is the more serious one in prostate cancer, those patients should be treated radically, in my opinion, even if they only have what looks like very favorable cancer. And the reason is the whole story is explosive accumulation of mutational events once you have the initial abnormality. Cancer's a genetic disease. So that's not a good strategy for long-term surveillance.
Any others? Yes, sir.
I guess this sort of builds on the last comment you had. So in cases where after the radical prostatectomy, there's persistent PSA, and the conventional treatment would be to have salvage radiation, but people aren't getting PSMA PET scans across the board.
PSMA PET scans.
Yeah, not getting it across
Yeah.
the board. Negative bone scan, but something shows up in the PSMA PET scan. Is that sort of where things are? You have that.
That's the challenge, and I bet that the next speaker is going to address that to some degree. He's nodding. So that's what we grapple with. And I showed the data, and I just showed one publication, but there's quite a few that suggest those cases of PSMA PET only metastases are much more favorable than the ones that are diagnosed with conventional imaging. So, this whole field is about risk stratification. You want to kind of try and figure out how much of a threat is this guy's disease. So it's the gestalt, so for sure. But yeah, so I can tell you at the moment we take those seriously. We pretty much treat them the way we would treat patients who have a solitary met on conventional imaging. But yeah, there's a risk we're going to go down this path of overtreatment again because it's so sensitive for small volume disease. Yes, ma'am.
But doesn't histology factor in? You've got the cribriform or intraductal on histological examination of the renal.
I thought you didn't know what Gleason grade was.
Well,
No, I'm sorry. I don't mean to give you a hard time. Yes, so because that's a much more advanced question. So there are these adverse histologies. The question she asked about something called cribriform or intraductal pattern. Those are variant patterns of high-grade cancer. You don't see them with low-grade cancer. And they confer a worse prognosis. They tend to be multifocal. They have a higher failure rate. Nothing good about them. So, that's part of the mix, Like, the whole thing is take every aspect of the patient's disease, their health, their other risk factors, and kind of put it together. So, yes, that goes into it as well. And like along with PSMA PET. But, there's a fundamental issue in these patients. Do they have metastatic disease or not? Once a patient has metastatic disease, they're in a whole different category. And we're talking now about risk stratifying metastatic disease. But they're already, it's potentially life-threatening disease once they have a metastasis. The question is, how long is it going to take? Okay, thank you.
Yeah, thank you, Dr. Klotz. Appreciate it, President. All right, so next we've got Dr. Andrew Loblaw, who's a radiation oncologist, clinician scientist, and dual professor in the Department of Radiation Oncology and the Institute of Health Policy Management and Evaluation at the University of Toronto. He is the co-chair of the American Society of Clinical Oncology's GU Advisory Group and co-chair of the GU Group for Cancer Care Ontario's program in evidence-based care. So please welcome Dr. Loblaw. Thank you.
So I want to shout out to Lori for doing all the hard work so I can just breeze through the rest of this. Thank you for the invitation, and it's lovely to be here. And it was great that the gardener didn't slow me down that much coming in, even though they're tearing up half of it. So here's some financial disclosures. They don't really have any play on today's talk. And objectives, basically, We're going to build on what Lori has talked about. I'm going to talk more about the radiation side of things for patients with de novo disease, those with localized prostate cancer. We're going to talk a little bit about options for patients who have failed radiotherapy. I didn't actually build a post-surgery set, but I'll talk to that because Lori, I think, set that up very nicely for us. And then we'll talk about management of disease that has spread or metastatic disease and the role of PSMA PET, as Lori mentioned. This is a very quickly changing field, and many of us don't have we like to have large clinical studies saying you should do this and don't do that. But we're in this period where this test has come in, but we haven't had the chance to do the high-powered, high-quality studies for us to say, absolutely, you should do this or that. So oftentimes, as Dr. Klotz mentioned, we get together, we have a huddle with all of our clinical experts, including radiology, pathology, urology, med-onc, Dr. Emmeniger there, and ourselves, and we figure out what's best for that patient, the individual patient in front of us. So things will get clearer over time, and it's an exciting time, but sometimes we have more questions than we have answers. Okay, management options. So basically, as Lori mentioned, there are essentially 4 different ways you can treat prostate cancer when it's being diagnosed and it hasn't spread. So active surveillance, if you look at the cameras, this is something that Lori and our group has, we started, I think, in 1995, Lori, and 1,500 patients, 25 years of follow-up at this stage. Surgery, this is just one of the techniques, the robotic surgery program. And there's 2 different types of radiotherapy. You can basically give radiotherapy from outside the body, called external beam radiotherapy, or you can give it from inside the body, and that's called brachytherapy. And within those 2 umbrellas, there's different types of external beam, and there's different types of brachytherapy. We can get into that if you're interested, but I'm just going to keep it very high level at this stage. So how does one decide? It's complicated. Obviously, it depends on a number of different factors. We can generally put patients into certain boxes, if you will, but certain circumstances or medical history or preferences might make a difference between a patient choosing radiation versus surgery or external radiation versus brachytherapy, for example. So these are some of the things that we take into consideration. Like Lori mentioned, if you have a patient with non-aggressive prostate cancer, and again, if we're thinking about the grade of the disease, it's the aggressiveness of the prostate cancer. It used to be what's called the Gleason score, and we made it easy because people couldn't understand why the lowest aggressive disease was 6 out of 10. They're like, how could 6 be the lowest? So we made it easy, maybe because we like putting things in boxes as oncologists. So grade group 1 is the least aggressive, grade group 5 is the most aggressive. So if you have a grade group 1 cancer, or selected patients with grade group 2 disease, watching is a perfectly reasonable and proven approach for these patients. The idea is not to forget about them, is to watch very closely and jump in with curative treatment when appropriate. And oftentimes people can get up to 15 years. Our average time to treatment in our surveillance program is 13.5 years. So if you're a 57-year-old guy and you've got low volume, non-aggressive prostate cancer, that gives you 13 and a half years on average to have a full, wholesome life. And that may include, avoidance of erectile dysfunction or incontinence or radiotherapy-related side effects like bowel bleeding and so forth. So younger patients, typically, we tend to go away from external beam radiotherapy. There is a small risk of a second cancer happening 10 or more years later, but again, young patients, my youngest patient was 42. You have to have a very real conversation with that patient about the risk of a second cancer coming along. Brachytherapy doesn't seem to have as high a risk, or at least the study suggests that it's not statistically significantly higher, but we still consult and counsel patients in that regard. Patients who are older, on the flip side, or have a lot of comorbidities, surgery is a pretty big operation, as Dr. Klotz will tell you, and we don't want a patient to have a blood clot or a heart attack or a pneumonia post-surgery that could actually be more life-threatening than the actual disease itself. So patients in their 80s, we tend to walk, not that we can't do it, but we tend to walk away a little bit further. The key here is multidisciplinary consultation. A patient should be seen by a surgeon and a radiation oncologist before they decide for treatment. I don't want to tell a patient about surgical side effects. I know quite a bit about surgical side effects and Conversely, I don't think Dr. Klotz wants to tell him about radiotherapy side effects. Our own personal experience and read of the literature is key. Just to give you a sense, in Ontario, less than half of the patients going for surgery actually get a radiation oncology opinion. We're doing better than we were before, but I'd like to see that closer to 90%. So multi-D consultation. And here are some of the things that are balanced between the two groups. So higher doses of radiotherapy are more effective. The analogy I use for patients is imagine radiotherapy dose like bullets in a gun. If you got 100 bad guys coming at you and you got 100 bullets in your gun, if you're a really good shot, you're going to kill them all. But if they give you 200 bullets in your gun, you have a much better chance, right? Even I, who's a horrible shot, can do a better job with 200 bullets. So the idea is more dose is better. And then Dr. Klotz mentioned this as well. It seems that MRI and PSMA PET scan will give us a sense of where the bad guys are hiding. If Osama bin Laden was hiding in the caves of Tora Bora and our military intel said it's those caves over there, we're going to put a few more megaton bombs over there. We're going to put a few more bullets in those caves. We're still going to bomb the whole area, but we're going to put more bombs over there. And we can do that now. We can paint the dose with radiotherapy, clonogenic density, so the idea is that where the more of your bad guys are hiding, or bad gals are hiding, you put more dose in that area. And we have that capability and technology now. So PSMA might change everything. This is a guy, I saw him like a month ago. He had intermediate risk disease. We don't normally do PSMA PET scans on this. I may have pulled a fast one on this one, but I got him scanned. So he had, and partly because he had, there we go, partly because he had this lymph node that was borderline in terms of what we consider to be concerning for metastasis. I'm like, I want to find out, because it changes my treatment approach, whether the patient has disease in that lymph node or not. So I got a PSMA PET scan. Turns out he had a bone metastasis and he had lung metastasis as well. So this is an otherwise intermediate risk patient that actually has disease elsewhere. But that's a good thing, because now I have a bunch of different tools that we'll talk about later that will help me manage that patient. But I need to know where the disease is and where it isn't, so I can use kind of like a holistic approach to solve that patient's problem. Local failure after radiotherapy, again, more bullets in our gun. The more dose that we're giving these days, it means we're having less failures. It used to be about 40% of our patients actually had a local failure after treatment. But as we've been able to confidently and accurately and safely deliver higher doses of radiotherapy, the chance of failure has gone down significantly. It still happens, but it's a lower risk than before. So, So there are a bunch of studies. This is a summary of the literature done by the UCLA group, led by Dr. Kishan. And you can see there's like if you put all of the studies together, there's over 150 studies with over 5,000 patients that have had either surgery or radiotherapy or some sort of what we call ablative therapy like cryotherapy or HIFU, post-radiotherapy. It used to be when I went through school, a long time ago, mind you, we were told once you give radiotherapy, you cannot give it again safely. And it looks like you can. And more importantly, it looks like it's just as effective as surgery in terms of getting rid of the disease. So here's radical prostatectomy. About half of patients at 5 years are free of disease, very similar to brachytherapy. SABR is still kind of like a little immature at this stage, but trending are all in the same place. HIFU and cryo, all about the same. There seems to be less side effects when radiotherapy is given a second time. There's less incontinence, less erectile dysfunction. That's important to some men, not all men, but some men. So it's, again, a multidisciplinary consultation with a patient. But the point simply is you can have treatment a second time if need be. Just like we were talking about after surgery, you can do radiotherapy afterwards. And Dr. Klotz brings up a very good point, which we're struggling with right now. We know, we used to say if you're at high risk for failure, we should treat everybody. And then we did a bunch of studies that said, well, instead of doing that, why don't we watch really closely, kind of like active surveillance, and jump in when we know the disease is coming back, but jump in at a time when we know it's highly curable. And so that's now our standard. And so PSAs of 0.1 to 0.2 are kind of the standard for jumping in with radiotherapy after surgery. The question then comes up about PSMA PET scans. The problem, as Dr. Klotz mentioned, is that the chance of finding any disease when your PSA is 0.1 is really low. It's about 15, 20%. And so the question is, do you wait until the PSMA shows something? knowing that the chance of radiotherapy curing that patient is lower, or do you jump in and ignore the PSMA PET scans? We're doing kind of a blended approach at this stage, I have to say. We get the PSMA PET scan. If it shows something, then we add that to the radiotherapy volume. We integrate that into our plan. But if it doesn't show anything, we just treat with what we know works. I think further studies are probably ongoing around the world, and we'll find out. So local salvage after brachytherapy, this is just an example. This is a hemigland ablation, so we treated half the prostate that showed biopsy positivity. Quality of life, this is urinary, bowel, sexual, and hormonal domains. You can see that those quality of life scores remain stable over time, essentially. The treatment doesn't add a lot of side effects to the patient. We can also do this with SBRT. SBRT is a high-precision form of external beam radiotherapy. Typically, we used to give radiotherapy once per day, 5 days a week, for about 8 to 10 weeks. Now we can do it in a week and a half with 5 treatments or even fewer. So SBRT is now being done in the salvage situation as well. And what happens if the cancer spreads, either at diagnosis or after treatment? There's a lot of work going on right now. It's probably a 3-hour talk. Urban would probably talk about this for about 2 hours, just this section alone. Suffice it to say, we have lots of different medicines available, either by themselves or in combination, that improves the chance of controlling the cancer for long periods of time, like 2 years more than just the hormone. So hormone injections are like our standard. That's kind of like our foundation. Hormone pills on top of the hormone injections adds about 2 years of life and probably about 3 extra years of cancer control. And there's some studies, I don't know, Urban, you're talking about this, but you can add in chemotherapy and the 2 hormone treatments to give even better results for certain patients. So the role of radiotherapy at this stage is experimental. I think within a few years, we're going to see that if you can see with a PSMA PET scan a few areas in the body, on top of the hormone treatments we're talking about, that'll actually consolidate or improve further the chance of controlling the disease. And our hope is that that will lead to a survival benefit. There's some small studies suggesting that that's true, but we're doing the confirmatory studies right now. Good. So, many managed options for localized prostate cancer. The take-home message for all of you is that patients should be seen. Those of you who have prostate cancer, obviously, you're being probably tapped on by the shoulder. If someone else, one of your friends, gets diagnosed, you're like, what's it like, Bob? What should I do? You get an opinion from both a surgeon and a radiation oncologist. Recurrence after treatment, whether it's with surgery or with radiotherapy, I believe you should have a PSMA PET scan as well as a bone scan and CT scan. And metastatic disease should be considered strongly for adding these extra medications that have a huge advantage for patients long term and are well tolerated. I'll take a few questions. Thank you for your attention.
You didn't mention.
Here you go.
Just like I can hear.
You mentioned HIFU or focal treatment in the salvage setting, not in the initial onset treatment. Is there a reason for that? Is HIFU not considered state-of-the-art or ready for prime time?
Yeah, so in Canada, HIFU and the other ablative therapies are not considered standard of care.
Yeah.
I think in the States, there are some groups of patients very selectively defined, Lori could probably speak to this better than I can, that there appears to be a benefit. It's never been compared against radiotherapy, so it's hard to make that judgment. I consider radiotherapy as the gold standard in terms of non-surgical treatment. So I'd like to see, if you're a new kid on the block, you gotta go against the king. If I'm, the previous Stanley Cup final winner, and you want to come in and have a place at the throne, then you got to play me and show me you're just as good as I am. Okay. Those studies are ongoing, I believe. Lori can talk about the Captain study. I think it's still going.
It's also not covered. That's one of the reasons.
Yeah, and it's
why
not covered. It's not
it's
not covered because we don't have the level, what we call level 1 evidence or strong scientific evidence that it's actually as good or better than radiotherapy.
Thank you.
You were pretty categorical about being able to re-radiate, it sounded like.
Yeah.
So, whereas I've just been told recently, 2 new mets in my pelvic area had all my radiation last year, so can't do that.
Sometimes you don't know what you don't know. We've been doing it for 11 years at Sunnybrook.
And like what would I present to my oncologist to say it is actually possible to do this?
Yeah, and you can say, can you refer me to Sunnybrook? So there's a great ad. I haven't found it on the internet, but there's this beautiful ad. I remember it was actually on the billboard on the Gardner, and it was from the Globe and Mail, and it says, "It's not what you know, it's when you know it." And I think we've had the blessing of working with some very forward-thinking and inspirational research leaders like Laurie and Urban, and so we've learned things before many other places in the world, and our job is to really disseminate that information. So it is unfortunately still well accepted that that's what you heard is true, but it's been false for at least 10 years. And I've shown you, like, it's not like it's a paucity of data. There's like 7,000 patients and 70 studies or something like that, or 150 studies. Did I see another hand? Or should we move on?
Questions?
One over here.
Mike.
Yeah, so I think it was after biochemical recurrence after prostatectomy that you want to get radiation at 0.1 to 0.2, but you don't see anything on PSMA till like 0.4. So do you just hit the prostate bed? Okay, so just sort of a shotgun approach and...
Yeah, so we know, historically speaking, that if we irradiate the area where the prostate used to be, what's called the prostate bed, and we've defined these by consensus, and actually from follow-up PSMA studies where we should actually be shooting our rays, then we know we're very effective like 85 to 90% of the time. The question is there disease outside of that area that also needs treatment? And then the bigger question is that better to get that up front, or is that better to get it at relapse? Like if I treat your prostate bed and you get a disease outside, you're going to fail outside eventually. I have a treatment technique for that when you fail eventually. Is it better to do combined therapy? My feeling is yes. And again, that's a bit of a debate in our specialty is like, do you add to the do you add to your radiotherapy volume or do you take away? So for example, if I do a scan and my PSMA is negative, some people will not irradiate that patient. I personally believe you should irradiate that patient, and if it's positive, add that volume to your radiotherapy volume. But those are questions that are being answered in studies right now.
Would you still combine ADT with your RT on that in that 0.1,
So
0.2?
we have calculators that help us figure out what your chance of cure is with radiotherapy and hormones. And what I do is I would present you with those two numbers and talk about the side effects of the hormone treatments and the duration of that treatment, and then we would come up with a decision together. That's how I approach it. So it's not a kind of like you should do this. There is some suggestion that if your PSA is above 0.34, treating the pelvis and adding hormones adds value. But I would walk the individual patient in front of me through the value of it, because a lot of guys don't want the hormone therapy, and I respect that.
Good.
Thank you.
Thank you, Dr. Loblaw, for everything that you've talked about so far. And I'm not sure if you can answer this or not. Wow, that sounds loud. You've illustrated the benefits of the PSMA PET scan, which, as we all know, are not really easy to get. And I'm currently just coming off of hormones, taking a break, which I was told earlier, don't go pay and get a PSMA PET scan. It's not going to show anything because you're on hormones. I don't know if that makes sense. But now that I'm coming off, I'm thinking I'd kind of like to know where these things are. So would it make sense then to go to Montreal or wherever and pay for the PSMA PET scan to be definitive, to know, yeah, it's there, it's there, it's there? That's kind of the dilemma I'm in right now.
Yeah, so if I can ask a personal question, did you have surgery or radiation treatment? Both. Surgery first, I imagine.
Surgery first.
Right. So your threshold for getting a PSMA in Ontario is 0.1. So the question is are we going to find anything at 0.1, or as Laurie says, do we wait a little bit longer? Perfectly reasonable thing to do, I think, is to do a scan when you want that scan, as long as it's above 0.1. I don't think you need to go to Montreal. If your scan's negative, we know that waiting to restart hormones till PSA of 10, Laurie was the the primary investigator on the study, where we looked at giving hormones for the rest of people's lives or a stop and start approach. And the stop and start approach was the trigger was when the PSA hit 10. So we know it's safe to wait till 10. Psychologically, you may not want to wait till 10, but we know it's safe. There's no downside from a cancer or survival point of view of waiting till 10. So what I do is I would say, hey, let's do a scan when your PSA is 0.1, 0.2. And if it's negative, let's do another one when you're 1.5 or something like that. If it's still negative, let's do it again at 5. And so I think it's a reason. So in Ontario, anything, if you've had surgery, 0.1 is the magic number.
So I'm at 0.8 now, as of Friday.
So you could get a PSMA.
Okay.
Again, we don't know that doing it now, but I think it's very reasonable. If you were working with me, I think it's a very reasonable thing to say,
Right.
Why not? Let's look around.
Let's do that. Okay. Thank you very much.
For Ontario citizens, it's not that, there's a few hoops to jump through.
Right.
So your clinician, whoever's looking after you, may not be facile about jumping through those hoops.
Right.
At Sunnybrook, which is one of the centers that does it, we're very facile. Like we can get, in a guy like you get a PSMA PET scan within a few weeks.
Yeah.
Maybe a month.
Yeah, it's about 2 weeks now.
So you may need to be proactive and say to him, listen, get me a PSMA PET scan. All he has to do is make the referral and you'll get it.
And there's a couple of community centers now that are offering this, that your physician can fill the same forms that we fill out and get you. There's 2 centers in Mississauga, and Lori, there are other ones? I can't remember. But for sure 2 in Mississauga, you can get it. It's just a simple couple-page form. It's very easy, and it's free. It's paid for by the government. So no need to go to Montreal. We used to send a lot of patients to Montreal, don't get me wrong, but with Lori, he started this, what's called the PrEP program, and that's really changed our access. Let's get Urban up here.
Yeah. Progress in Canada. Thank you. Thanks, Dr. Lobo. Appreciate it. Okay. Next on the agenda here is Dr. Urban Eminger. There we go. Is a medical oncologist at Sunnybrook. It's an advertisement for Sunnybrook, I think. Research Institute in Toronto. He is also the director of the Prostate Cancer Bone Metastasis Clinic in Odette Center, Cancer Center, and the assistant professor in the Department of Medicine at the University of Toronto. Please join me in welcoming Dr. Eminger.
Thanks for being invited to this meeting today. So I think we're a little bit behind in time, and I tried to go my slides a bit faster than maybe that I had scheduled. I want to start with my disclosures. We do a lot of studies, and usually studies are a big option for patients to get access to medication that might not be available otherwise. So patients often tend to benefit from that. What I will do is that I want to speak about metastatic prostate cancer, because this is the type of patient that I see as a medical oncologist, and it can mean many, many different things. And I have 2 key messages. The first is what I will just speak about, and then the last one is actually at the very end of the presentation. I hate the term stage 4 prostate cancer. Stage 4 usually means that patients have the impression they're just a few weeks close to die. I have seen patients with stage 4 prostate cancer living for more than 20 years. This is not the rule, but patients that come to see me typically have a life expectancy of counting in years, but unfortunately we also can't cure them. And we use different types of treatments. I will focus on the treatments that are available here in Ontario. These are hormonal treatments. These are chemotherapy treatments. We have a new type of treatment called PARP inhibitors that are called in chemotherapy tablets. And then today, I want to speak about radioligand therapies as well. We have some kind of an old-fashioned drug called radium-223, and then we have the more modern version, which is Pluvicto, and I'm sure that you have heard about Pluvicto today as well. And at the end, I want to tell a little bit what's coming down the pipeline. I want to start with this slide here. So around 10% of patients in Ontario will be diagnosed with prostate cancer and already have metastases. And that has a huge impact on what type of treatments we use. And you can see typically these patients get a form of hormone treatment, which is to bring down the testosterone readings, which is combined with something else. And this is listed on the left side here. Then there's around 20 to 25% of patients that have localized prostate cancer. They might have surgery, they might have radiation therapy with the idea in mind to actually help them be cured from their prostate cancer, but eventually the cancer is coming back. And eventually, they might also have metastasis, and they might feed into this group of metastatic castration-sensitive prostate cancer. And this is around 1/3 of my practice. 10 years ago, it was barely any patient I saw with this type of conditions. And the reason is that the treatment paradigms have changed dramatically. We have a better handle on how to help these patients to live by at least a couple of years longer than what would have been in the past. On the right side, you see the box of castration-resistant prostate cancer. These are men that have already very low testosterone readings. The cancer cells have adjusted to that, and these are the patients that are the most difficult to treat, but you see there's a lot of different treatment options that we have. And then in the middle, you see a group of patients that is such a small segment in my clinic that I will not speak about it, but I want to use it to briefly introduce the PSMA PET scan paradigm into what I do as a medical oncologist. So if you have patients that get bone scans done, CT scans done, and they're all negative, but the PSA goes up, and they already have a low testosterone, we call these patients having non-metastatic castration-resistant prostate cancer. We know how to treat these patients, but we know that these are patients that have metastasis, and we know that if you do PSMA PET scan on these patients, more than 50% will have metastases that have fairly widespread already. It doesn't matter whether you do PSA PET scan or not. At the moment, we treat them the same way, and I usually do not recommend patients to get a PSA PET scan done. The only reason why I might order a PSA PET scan these days is that if I have a patient that has an interest to get Pluvicto treatment done, unfortunately, it's not yet funded. So this is a very small minority of my patients that can afford to actually get Pluvicto treatment done either in Montreal or in Burnaby, BC. And hopefully this will change anytime soon. There will be some decisions coming up soon. I want to start with this cartoon here that I took from Wikipedia, which really shows that prostate cancer is a hormone-driven condition. It has to do with something called the AR, or androgen receptor. This is like the motor of prostate cancer cells. It's also the motor of normal prostate cells, but in prostate cancer cells, it helps to produce proteins that change the characteristics of these cells so that they can start to spread, they can start to grow more aggressively, and they also produce a lot of PSA. This is why PSA is typically such a good marker, because when there's an androgen receptor around that can engage with male hormones, that leads to upregulation of PSA, and you have higher levels of PSA that you can measure in the bloodstream. So the first thing that we typically do in patients that have metastasis, we try to bring down the hormone level as low as we can. And the way we do that is with either injections, either in the tummy, buttock, every month, every 3 months, 4 months, 6 months, you can choose. And since recently, we also have access to medication called Orgovix, which is Health Canada approved. It's available in Canada. It's not yet funded, but this is a tablet version of getting the hormone treatments low. With the injections, I think the emphasis is more on the physicians to make sure that the injections are done on time. With the tablets, obviously, the emphasis is then on the patient to make sure that they don't miss these tablets too often. Unfortunately, hormone therapy comes with side effects, and I have listed a few here. I will not discuss all of those, but I want to make 2 or 3 points that are close to my heart. The first thing is that with hormone treatment, fatigue is a main side effect. Patients tend to be less active, but that will actually also be a reason why they might lose muscle strength, and it's important to try to stay as active as you can. This is also helpful for having healthy bones, because the bones can get weaker over time as well. And aside from taking calcium and vitamin D, patients should try to stay as active as they can be. We also typically monitor patients whether they have a risk of becoming diabetic or whether they are already borderline diabetic, because the risk will increase when you get hormone treatment. And patients with heart conditions, we know that we have to be really monitoring closely because they have a high risk of having worsening of their heart condition, or patients that never had a heart condition before might actually declare the heart condition in the first few months when they start the hormone treatment. In terms of the treatment options we have, and I have listed 4, the hormone treatments are the ones that are the most powerful. And it's probably not fair to say that in a sense that the response rate to hormone treatment is higher than, for instance, to chemotherapies. We also use these agents in different stages of prostate cancer. For instance, chemotherapy is rather used for later stages, so we expect that the response rate will be low. But if somebody, for instance, had hormone injections done, testosterone is low, and then they have developed what we call castration-resistant prostate cancer, and then start on a medication such as abiraterone or darolutamide, apalutamide, enzalutamide, they have around a 75% chance of having a drop of the PS of at least 50%, which means that they often will take these drugs for between 1 or 2 years. So I expect these patients to have a response. It's actually rather the exception that they will not have a response. Now, these agents come with side effects, and some of them are listed here. More hot flashes, being more tired, high blood pressure is a common theme amongst these agents. Some of these side effects are specific to the drug. For instance, abiraterone comes with a certain risk of having liver issues, also having higher blood sugars. And enzalutamide and apalutamide have a very small risk of inducing seizures. The one important thing to know is that when you start with one of these agents, the chance of a response are around 75%. When the cancer becomes resistant to these tablets and you switch to another type of hormone tablets, the chances that this will work for more than a few months is actually very low. So typically, you should use at least one of those agents for a patient at a given time, and the uroncologist will decide together with you which is the best treatment option. But once this treatment stops working, then you should try to get some other type of drug that you can use. And typically, this is where the discussion with chemotherapy starts. And they use primarily 2 drugs called taxane chemotherapeutics. Taxanes are chemotherapy drugs that interfere with microtubules. And microtubules are somehow a little bit like a traffic system within a cell. So the microtubules help, for instance, the androgen receptor to go to the right place to induce the growth of prostate cancer cells, and we can interfere with these microtubules when you use the taxanes. Taxanes are given intravenously, typically every 3 weeks, and they definitely have side effects, more so than hormonal agents. They also have serious side effects, such as, for instance, infections, which eventually can also be lethal. Patients might feel under the weather for the first few days when they get chemotherapy afterwards. Feeling nauseous is typically not a big issue with these type of chemotherapy drugs. That's different for other types of chemotherapy cocktails. The hair usually gets thinner, although with capacitaxel, that is actually sometimes even the opposite. I sometimes have the impression that if patients get capacitaxel chemotherapy, the hair starts to grow back and grows even more thick than before. And unfortunately, these drugs can also damage the nerve endings. That can mean that patients start to have tingling of the fingertips, some numbness, or they might have issues with the taste buds, that food just tastes slightly different. Then since recently we have access to 2 drugs called olaparib and niraparib, which are a group of medications called PARP inhibitors. PARP is an enzyme that is important for maintaining the integrity of the genetic information in a cell or in a cancer cell. And these agents actually induce some genetic changes, some genetic damage. And certain prostate cancer cells can't handle these type of damages. And these cancers are found in around 10 to 15% of patients. And how do we find out about these patients? And this is actually important because patients that don't have these type of prostate cancers with these changes will not respond to the PARP inhibitors. We do a blood test, and ideally we also do some testing on the tissue. And this is why it's important at some point to get access to tissue, to have a biopsy at some point, be it from the prostate or maybe later on if there's any swollen lymph node, that you can also get some tissue from the lymph nodes. And as a side effect, and this is actually a good side effect from doing this type of analysis, we can identify families with a higher risk of having prostate cancer, but not just prostate cancer. This is the blood test that we do. With a gene called BRCA2, which stands for breast cancer 2, is the driver of many aggressive types of prostate cancer. It can be passed on from one generation to the next one, and the chances are 50% that if you have a prostate cancer with a BRCA2 defect, that your son or your daughter might have the same defect. In the daughter, obviously, she will not have prostate cancer, but she might have a heightened risk of having breast cancer, having ovarian cancer. And this really gives us the tool and the opportunity to intervene before these family members become cancer patients on their own. And I can give you one example of one of my patients that went into a clinical study. We did all the testing as part of the clinical study. And in his case, he was found to have a BRCA2 defect. He was in his early 60s. His sister was 69. She tested positive as well. She now actually does breast cancer screening. She had her ovaries removed. to minimize the risk of becoming a breast cancer patient, ovarian cancer patient. His brother is 73. He has the same genetic defect, but he's not yet a prostate cancer patient, and he now really does prostate cancer screening with somebody that has experience in doing that. So that really can empower families. It's not easy to know about this type of information, but this is actually one of the biggest changes I've seen in terms of impact over the last few years. Now, the last group of medications are radioisotopes or radioligands, and this started more than 10 years ago with a drug called radium-223. Radium behaves a little bit like calcium, so when injected intravenously, and this is done with this drug every 4 weeks, times 6 in a row, then this drug tends to go to places where there's bone remodeling. What does that mean? That in bones, there's always a degradation of bone material, there's a buildup of new bone material. Around 10 to 50% of the bones are replaced each year. But when you have prostate cancer spread to the bones, in these places where the prostate cancer cells are hiding, there's more remodeling going on. This is precisely the place where this drug is going to. It works at a very short distance, so it can kill around 10 cancer cells that would be lined up in a row. It does not damage the bone marrow so much, so it doesn't have a lot of side effects. And this is probably the treatment that is the best tolerated that would even prescribe in a 90-year-old if the situation would be right. But it has certain shortcomings, which I will comment on in the next couple of slides. And it goes up against a more modern version of radioligand therapy, which is Pluvicto. And I understand you already have heard about Pluvicto earlier today, so do not go into the details of how this works. And it's the same principle as we use PSA PET scans. PSA PET scans are very sensitive. Pluvicto is just a drug that can really go after cancer cells that are hiding wherever they are in the body, which they can reach, even places outside of bones. Radium-223 is restricted to bones, but Pluvicto can actually work outside of bones as well. Now, these two drugs have never been compared to each other, and I can't tell you which one is the better one. I think most of us have a certain bias that we assume that Pluvicto is the better drug, but that might not be right for the same patients. As you can see, both drugs are Health Canada approved for different patients. Radium-223 is for patients where the cancer is primarily in the bones. It does not work against swollen lymph nodes. It doesn't work against spread of the cancer in the lungs or in the liver. And Pluvicto is approved for patients that have had one of these novel hormonal agents, such as abiraterone, apalutamide, arudamide, or enzalutamide, and they need to have had docetaxel like chemotherapy or one of the taxane chemotherapeutics. In terms of access, radium-223 has been funded since more than 10 years. Pluvicto is not yet funded, and this decision will come out anytime soon. We'll see how this will be funded. This is an expensive drug, and maybe we can discuss that afterwards. In terms of logistics, when you started to use radium-223, we had the impression this is a complicated drug. It's not so easy to use, but actually I've learned to do that. The logistics with Pluvicto will be more complicated because this is a drug with a relatively short half-life, meaning that the drug and the patient have to be at the right place at the right time with not that much leverage to do the treatment today or tomorrow. With radium-223, if you have a patient that has a treatment booked on Thursday and he can't make it, you can still treat him on Friday. Probably you can't treat him on Monday, but you can treat him on Friday. The other thing is that when you get radium-223, this is a type of radioactivity that is very powerful, but it would not go through your skin, so not radioactive for others, whereas Pluvicto is a type of radioactivity that you will be radioactive as a patient for a few days. That means that you can't just hop into plane, hop into train. You should distance yourself from family members. You should stay away from kids. You should stay away from pregnant women. So it is more complicated in this sense. Both drugs have shown to prolong the life of patients and to delay the onset of symptoms or to help with treating symptoms related to prostate cancer. In terms of side effects, again, radium-223, very easy. Typically, patients do not complain about side effects. With Pluvicto, it's a little bit between chemotherapy and the hormone tablets in terms of the intensity of the side effects and in terms of the severity. But the side effects are slightly different from chemotherapy. For instance, dry mouth is probably something relatively unique to Pluvicto and can be more pronounced than when you get other types of cancer treatments. And really, Pluvicto can be seen as a little bit a more comprehensive type of treatment than radium-223 because it really works outside of the bones. You can also use conventional scans to see whether patients respond or not. The PSA typically is reliable, whereas PSA readings are not very useful to know whether you do the right thing when you use radium-223. So how do we assemble a treatment plan for a patient? So first of all, each patient is different. Oncologists are different as well, but we have a few rules that apply. Typically for metastatic castration-sensitive prostate cancer, we start hormone therapy to bring down the testosterone readings. We add something else, some of the novel hormone agents, sometimes radiation therapy, sometimes even chemotherapy. For metastatic castration-resistant prostate cancer, we usually stop the prior treatments with the exception of the hormone treatment that keeps down the testosterone at very low levels. And we add one thing after the other. And the sequence, how you do that, which drug you use, whether it's drug A or B or C, or maybe you start with C and then you go back to A and B, it really depends on where the cancer is, how active it is, whether the patient have other health issues, whether they take other medications that might interfere with the treatments. So this is really something that you will discuss with your oncologist to come up with what the best treatment choice is. And sometimes access to drugs might have an impact on this as well. And this is where also clinical trials are important. Sometimes clinical trials can give you access to medication that you can't get otherwise. I have treated no single patient with Pluvicto in our place as part of a standard of care treatment, so that the patient would just come to us and get the treatment done. But we have treated, or I've treated more than 30 patients as part of clinical studies. And I have sent a few patients, for instance, to Montreal for getting these treatments done. But then they have to pay out of pocket. When you switch from one treatment to the other, you want to go from a hormone treatment to chemotherapy, radioligand, maybe back to chemotherapy. But again, you usually don't use one hormone treatment after another. And then where does radium-223 fit in? Radium-223 is actually fairly simple. As long as the cancer is just has spread to the bones, you can use it whenever you want to use it. The way we can use it is actually more liberal than the drug has already been studied. So in the initial trial that showed the benefit of radium-223 was primarily for patients that had chemotherapy or were not fit for getting chemotherapy. We don't have any restrictions when we think it's right. In an 85-year-old gentleman that doesn't want to have chemotherapy, radium-223 might be a good option that would follow, for instance, treatment with abiraterone. And for Pluvicto at the moment, we will be restricted going forward for the next couple of years to patients that had that chemotherapy. Now, what is down the road? I think in the last 10 years, we have seen that most trials try to be more aggressive, to add things together and to do combination therapies. And now I sense that the pendulum is swinging back, that we rather want to try to identify who really needs more aggressive treatment. And maybe there's a lot of patients that we tend to overtreat. And PSA PET can potentially be a factor to overtreat patients because you see more cancer, you see more spread when you do a PSA PET scan. And it's very hard for us to actually integrate PSA PET scan information in our treatment plans because everything I know as a medical oncologist is based on conventional scans. The second thing is that we tend to use agents when we develop them in late stage of prostate cancer, then we use them at earlier stages. So a lot of these drugs, that includes, for instance, Pluvicto as well, will now be tested in localized prostate cancer in patients that don't have any metastasis but just have a local prostate cancer in place. And time will tell whether this is the right way to go. In terms of hormone treatment, again, this is probably the most powerful treatment that we have. We use the injections. This is something that in essence has been done since close to 50 years now. We can use drugs such as Casodex or bicalutamide, which the role has actually gotten less and less important over the years. We have now second-generation drugs that everybody should be considered at some point, such as abiraterone, darolutamide, apalutamide, and enzalutamide. But now we start to think about third-generation drugs. And these are drugs that work in different ways. They no longer really interfere with the amount of male hormones around, but they can actually remove the excessive amount of the androgen receptor that you find in prostate cancer cells. Or they can not only deal with male hormones, but they can actually remove other types of hormones as well. Again, these are early stages and probably will take another 5 to 10 years before we know where these drugs really fit in. And then even for Pluvicto is just the first, or maybe it's a second generation radioligand therapy if you say that radium-223 is first generation. But we think about third, fourth, and fifth generation drugs that use other types of isotopes and have different characteristics than lutetium or radium-223, or that do not target prostate-specific membrane antigen, but other molecules that are expressed at the surface of cancer cells. For instance, a molecule called STEAP1, which is quite is quite the focus of a lot of study activities. And then we start to combine these things in the hope that we can actually reduce sometimes the amount of treatment that you use of a given type of treatment so that we have less side effects. So if you use different drugs, use them less intensely, you still might have the same or a better anti-tumor benefit, but you have less side effects overall. And instead of having one conclusion slide, I really want to finish up with this here. And again, genetic testing is important. Every man in Ontario that has metastatic prostate cancer should have access to a blood test. And if there's tissue around, he should have access to tissue tests. Because, again, this is not just about helping you as a patient, it's also helping you as a patient that has other family members potentially that might be at the cusp of becoming cancer patients. And if you can help them that this doesn't happen, then this is a big benefit overall as well.
Thank you, Doctor.
I'm glad you hit that last slide because I was already prepping for a question on somatic testing that you touched on earlier in the Cascade study and so forth. So in the case of a situation where you don't have tissue availability, I've got some remnants from both the iliac lymph nodes and the prostate itself, but it's not enough tissue to do proper genomic testing. And I'm examining right now the Foundation One liquid biopsy. How beneficial is that liquid biopsy? I've been hearing different war stories about the fact that, yeah, you find a lot of stuff, but we don't know what to do with it right now. Is there some advances being made, especially in the area of immunotherapy, when we do find something in the epigenetic sequence there, to be able to do some therapy with it afterwards?
So when it comes to liquid biopsies, it's just doing a blood test and analyzing the genetic information that comes from cancer cells and can be identified and isolated from the bloodstream. This is something that we have very limited access in our public health system at the moment. And there's also, I think, very few laboratories where I would trust that they do a good job to really get as much information out of it as possible. This has to do with the fact that not every patient at a given time is a good candidate for a liquid biopsy, because the more material you have, the easier it is to do the test. And if you do the test at the wrong time, let's say, for instance, you start the treatment, PSA goes from 100 to less than 1. That's probably not the right time to do the liquid biopsy. So you have to do it at the right time. And then it really has to be analyzed by the right laboratory. And the way we analyze it now compared to how we might do it in maybe 5 to 10 years down the road is probably quite different. But it sometimes can replace a proper biopsy. But I think for most of my patients within the Ontario health system, we still rely on the conventional biopsies. And sometimes you have to wait until a good lesion pops up, and then obviously timing is of the essence. In our case, it takes a couple of weeks to get a biopsy done, then you have to get the material processed, and then you have to do the genetic testing, so that can take a few weeks. So the timing is important, because when you have a cancer that has seen different types of treatments, you sometimes need to decide relatively rapidly what the next line of treatment should be. And I can tell you that I spend probably each week between 1 or 2 hours to chase biopsy samples from my patients. This is actually very difficult to sometimes find out where the samples are. And it's also true that the older the sample is, the less likely it is that the sample will be informative. And if it's just a small biopsy, sometimes it's simply not enough to do the test.
I have a question for our 3 doctors. What clinical trials are ongoing at Sunnybrook? Dr. Klotz, maybe.
So I can maybe start. This is a loaded question because these things are changing almost on a monthly basis. I think in our case, We have at the moment one trial with immunotherapy. Immunotherapy is something that has not really worked out in prostate cancer so far. So we had at some point a few trials at a given time. Now we are down to one. I think this is an area where I don't see that much of development coming. We are about to open trials where we test one of these third-generation hormonal agents. We have a trial that just opened where we use a liquid biopsy to identify patients that actually might be good candidates to switch from, for instance, abiraterone to enzalutamide, because there are definitely some patients that benefit, but the majority will not. And the study is done in a way that you do the blood test, and 50% of the patients will be treated according to the result of the blood test, will tell us either use a hormone drug or use chemotherapy. 50% of the patient, the physician has to decide with the patient which drug type to use. And it will be interesting to see whether physicians are better than the blood test, and I suspect the blood test will be better than the physicians. And then we also have trials where we integrate novel Pluvicto-like medications into our treatment paradigms, for instance, in combination with hormone tablets, in combination with chemotherapy. So when you ask me today, this is what we have at the moment. We also have a trial, for instance, where we try to treat patients with two types of treatments at the beginning, and when they have a really good response, we actually remove one of the two treatments. But if you ask me 6 months down the road, it might be a completely different scenario. And I think for Dr. Klotz and Dr. Loblaw, I mean, they can comment on this themselves.
And I'm going to ask one, Ed, is there I know in the U.S. and in our website, we're promoting a couple of like AI-powered clinical trial finders or navigators. And one's called Massive Bio, and then another one is with SurvivorNet. But I'm happy to pass it on to anybody that likes those. You can, I know they do searches up in Canada as well. But Dr. Klotz?
Yeah, it's a shifting sands for sure, because trials open and close all the time. The two main ones that I'm involved in right now at Sunnybrook in the localized space, one is a diagnostic trial comparing in men with elevated PSA. So we've moved to imaging before biopsy. The question is, how are they imaged? So there's a new technology that was actually invented at Sunnybrook called high-resolution micro-ultrasound that's now going all over the world that looks very competitive to MRI and is a lot cheaper, doesn't involve contrast. So it's a 3-arm study comparing MRI to high-resolution micro-ultrasound to the combination prior to biopsy, called the Optimum trial, worldwide trial. And the second one is the other big Sunnybrook invention, TULSA, which is one of the energy-based treatments that Dr. Loblaw mentioned, that's MR-guided transurethral ablation, also came out of the imaging research group at Sunnybrook. Also I've been involved with it for 20 years in the development of it, and it's also now going all over the world. So it's a very audacious trial, which is comparing TULSA's primary treatment for prostate cancer, this thermal ablation, MR-guided, to radical prostatectomy. Now, you might ask, why the hell should anyone agree to be randomized between radical prostatectomy and TULSA? Because patients tend to decide they want one or the other. And the hook, at least in my center, is they get it for free if they go into the trial. They have to accept a 1 in 3 chance of getting surgery. But for a lot of these guys, the ability, because this is an expensive technology, it costs $30,000. Big chunk of change. It's an expensive technology. It involves big whole team of people, MRI for several hours, et cetera. So that we have others that are ongoing, but those are the two that we're in a leadership role and are very excited about. No one has pulled off a comparative trial of surgery versus an energy-based intervention, HIFU, cryo, et cetera. This would be the first. We're very excited. It's accruing.
It's probably better if we just emailed you, but we have about 10 trials open. So in low-risk patients, we've got a registry that Dr. Klotz and I have mentioned that's been going on since 1995. For the intermediate-risk patients, we have a couple of trials, one looking at low-dose rate brachytherapy versus 2 treatments of high-dose rate brachytherapy. That's a Canadian study, randomized 1-to-1. We have an internal study that looks at 5 treatments of stereotactic radiotherapy, which I mentioned is a high-precision form of radiotherapy, versus a 2-fraction more ultra-high-precision approach. There seems to be a sexual quality of life advantage with the 2 treatments. We've got another one using, most of our radiation machines use CT scans to guide the treatment. We have a special machine that costs about $20 million that uses MRI to guide the treatment, similar to Lori's Tulsa machine. So we have a study called Destination, where we give 5 treatments, no gold seeds, very, very tight margins. Again, the promise is that men's sex life and bowel and bladder function will be better. And then in the high-risk space, we have a brachytherapy versus stereotactic treatment that I'm leading through. It's actually an international study. And then finally, in the metastatic disease site, Urban's talked about the combination of hormones and the hormone injections. So patients with metastatic disease with 5 or fewer spots get randomized to radiotherapy to those spots or just the drugs alone. Those are the kind of the main ones that we have. So I know that was probably, you were thinking it's going to be an easy answer, but, and like Lori says, and Urban says, it changes all the time. So yeah, we probably, within our 3 groups, we probably have 30 trials open at any given moment. And it's hard because you can't, there's no one place to find all that stuff.
I see an opportunity. We need a listing of all the trials going on. Any other questions? Because we are kind of getting edged out on time, but we have the last speaker is going to be very important, and we're going to kind of like roll over into our entertainment time, which I think everybody was up for. I think it's a very important topic that we're getting through. I think that everybody's learning a lot. And so I'm going to introduce the last speaker, ask everybody to kind of hang on, and we'll go down and have a Molson or a cocktail afterwards. So last is Dr. Ephraim Parent. He's a radiologist and nuclear medicine specialist at Mayo Clinic in Jacksonville, Florida. Dr. Parent's been involved with the Society of Nuclear Medicine and Medical Imaging, or Molecular Imaging, for years. He's formerly the chair of the Society's Prostate Cancer Outreach Working Group, and this year he's becoming the chair of the entire Outreach Working Group. And so please welcome me or join me in welcoming Dr. Parent.
Thank you, Mike. I'm grateful for all our speakers beforehand. I'm going to truncate dramatically what I've prepared for the sake of time, but try to maybe clarify a few points that maybe have been asked. And this is not, there we go. Okay, there's my stuff. You don't need to, right there. I'm going to skip a lot of this stuff. The one thing I was going to make a point of is this concept, is my, oh, it does work. I don't know. Oh, there we go. Okay. No one is big enough to be independent of others. And as everybody here is aware, whether you're a clinician, you're a patient, or you're a family member, there's a lot of different people involved in the care. And really, I would say the Mayo Clinic philosophy, but also just my own philosophy, is like it's close coordination. I'm every day calling my oncologist. Like we don't page each other. I just have their cell phones. We're like, okay, this is where we're going. Let's talk about these patients. Talk about radiation oncology. So it's essential to have very close communication between all the groups. And this has kind of been hit on, but this is prostate for the most part what we see, and just again really quickly about it. We get it diagnosed, and it's going to go up, and then usually we get some kind of definitive, radiation therapy, surgery. And it hits down. And then at this point where it starts, that PSA starts coming up again, which it always done unless we got the whole thing out. This is the biochemical recurrence that we kind of talked about. This is where we're looking at our PSA numbers, going up from 0.1 to 0.2 or what have you from that kind of low point. And usually then we're getting these initial, now we're put on hormonal therapies, these kind of first-line treatments, and there's usually going to be a drop. And then this is now where we're getting, after the hormonal therapies are stopped working, then we kind of start having this kind of waxing and waning pattern, and we stick on hormonal different chemotherapy agents. I'm not going to talk about this, but this is this castrate resistant because it's escaped the hormonal picture. And this is where really I would say PSMA, which is all I'm going to be talking about, is in this area with therapies. I'm going to skip, just for the sake of time, talking about PSMA in the U.S., and again, I'm U.S., I'm not Canadian. Sorry, my grandfather was French-Canadian, but I don't really know the financial and legal how these things get done here, so if I'm speaking of something that's completely inappropriate, you're going to have to just forgive me. But we have 3 agents for PET that are approved in the US. And honestly, all I really want to say with this is that if you're getting and this is our one therapy agent, the Pluvicto that people talk about, we don't need to talk about the chemistry of them. Ultimately, what I'd say is they might look different, and they might have different isotopes, they might have different tags, but I would say really everything I've seen, except for 1 or 2 things yet that are not approved, they're all going to behave very similarly. So I would not waste effort trying to shop around, and it sounds like there's some access issues of getting the PSMA PET scan, but I don't think it's worthwhile trying to say, well, I want to get a F18 PYLARIFY because I heard it's better than the PSMA 11 that gets a gallium tag. I mean, there might be some differences, you know, maybe be able to hear somebody say, hey, I'm a real champion of this, but I think ultimately, whatever you can get approved and paid for, without having a huge financial issue, I think it's going to be comparable. What we care about really now is, yes, there's issues of wanting to identify spots of disease that we could target with radiation therapy, or hey, we're already going to know if there's biochemical recurrence or something like that based off of the lab values, but you know, really why we'd want to do PSMA PET is to either identify oligometastatic disease or primary disease if you haven't had definitive initial fund, or say, do they qualify for therapy? And that's really what is going on here. This is why we care about this. And again, I think everybody knows how this works. We have this PSMA molecule that's tied into the lutetium. This is why it's indicated here in the States. You have to have failed the hormonal and the chemotherapy, and so it's kind of a 3rd-line treatment here. There are trials. I'm trying to talk only about clinically kind of outside of trials. But there is efforts, there's trials ongoing PSMA addition that could be getting stuff to first-line treatment. We have to stop?
No, but could you use the mic?
Oh, I'm sorry.
Recording is having a hard time. This room is small enough for the recording.
Okay, I'm going to talk like this and be very quiet, except talk very closely into the microphone. So you have to have failed it. So again, I don't know in Canada how it is. But hopefully this can change, because I think if we can bring this forward, the quality of life that a lot of people have talked about will be useful. But again, we don't have that data yet. Come on. Okay, this is one thing I wanted to talk about why PSMA and how we should how I would suggest that PSMA PET should be used for identifying for treatment. So it makes sense that if I'm doing a PET study and I'm using PSMA PET to identify disease, the effectiveness of the therapy that's doing targeted radiation to those lesions is only really going to be useful if those lesions have uptake, right? And so all the big trials have looked at that. That makes sense. But what we know is that it's pretty consistently, there's a subset of these patients with metastatic castrate-resistant prostate cancer that have PSMA of a disease, but they also have what we're going to call it discordant hypermetabolic disease, meaning that it doesn't really have PSMA uptake, but it'll have a glucose FDG, people might have heard of, that's showing that. So that means that there's something that's changed with this prostate cancer. There's heterogeneous distribution, and these people aren't going to do as well. So just to point this out, so this is coming from literature. This is a person here. You see this inguinal lymph node right here. So on FDG, it's lighting up. PSMA PET, we don't really see it. That's not a good situation if you're trying to get radiation in there. This person is somebody that we would like to see where you have PSMA avid uptake here in this external iliac lymph node, but we don't really have FDG. We do know, and again, the reason why this matters is jumping to this, is that if we treat people with discordant disease, they're not going to do as well. And this is if you look at these Kaplan-Meier curves, this is really striking. So a lot of times, if you end up start going to PSMA and they're saying, look, I want to do a secondary scan before you're getting therapy, it might be due to this. So let me give you an example. I'm going to give you just to this case. This is a patient that we had like a year ago. So progressive disease, and here on my left, I can't go back. No, we just have to go forward. That's how it is. But the images on the left are FDG, images on the right are PSMA. And what you can see is that you have a obturator lymph node here that's hot on FDG, not hot on PSMA. But we have, This is really, I apparently have some, where am I hitting here? Because I'm just, this is like that skill set where you're like round hole into a square peg or something. I don't know what's going on here. You're trying to advance? Yeah, I'm just trying to move it forward. Move the slide forward? I'm getting a red light on my thing here, but I don't know. Nothing's happening. So anyway, while we're trying to figure this out, this person had both PSMA avid disease and disease that didn't have PSMA uptake. And at talking to a multidisciplinary board, so this is again showing, I'll tell you when to move it forward, and I can do my green pointer, okay? So again, lymph nodes lighting up on FDG, not really PSMA. Let's move forward another slide. Oh, apparently so. You could maybe shut it down and then start it again and just go to, I don't know. This is where we give up control and it freaks us all out. We're just like, never again. But anyway, this patient, he had disease. He had PSMA avid osseous disease, but discordant stuff. So we did not treat him. And this is a thing that we look at closely. So when we're getting referred to from our oncology colleagues for PSMA Pluvicto therapy, and I'm going to let you tell me when it gets advanced so that I can turn around and start doing something. We look closely at one of the things, we look at lab values, we look at make sure that they've had the appropriate therapies, and then we also want to make sure that the imaging implies that this patient will have a good outcome. And we compare how much PSMA uptake is this into physiologic organs. This is kind of like a standard, I'm talking not just standard clinical care, we want to compare it to liver. And sometimes, unfortunately, you have this hard situation where you're saying, look, this is not really appropriate for therapy. Yeah, I'll let you keep advancing. So tell me when to stop. Keep going. Keep going. Keep going. Just, all gas, no brakes. Let's go. Okay, keep going, keep going, keep going. Go. Stop. Anyway, okay, perfect. Okay, so you can see here, like, this person did have disease, right? We're not saying he didn't have PSMA of a disease, but there's clearly disease that wasn't. So he's not going to have a good outcome. What does this mean? This is where you have hard conversations, especially because these patients have already progressed on chemotherapy by the time we're getting to see this here. But there are maybe secondary therapies, stuff off label that one could look at, but ultimately for PSMA therapy, it's not appropriate. So we look at these patients. I'm going to skip this for sake of time. I'm going to skip these trials, but basically this is the justification for how this works. The patients did well. Let's just leave it like that. What's interesting here on this trial is if they compared the PSMA Pluvicto therapy compared to the chemotherapy, cabazitaxel taxane therapy, early on they don't see any difference in outcomes. But it's really out here where you're seeing the difference in how people are progression. So again, when we're looking at this is not going to be an immediate, like now we're good, but it is, we start seeing these changes downstream. And I also want to make a point of this, is that this is not a curative therapy, right? This is, every time I talk with somebody, I'm going to be treating them and say that you will progress. I don't know how long it's going to take, but understand it's going to come back. We're not going to cure you. Because what I want is that everybody to be on the same page with what we get going on. For the sake of time, I want to go to just kind of what we do rather than kind of talking about all this data. Alpha therapies, people have probably heard of. That these are a different isotope that is a helium nucleus. It's like the equivalent of a cannonball versus a BB gun. These are ongoing. We're doing trials on these. A lot of places are. There's going to be a real problem with dry mouth, because if you remember, like you see here, the salivary glands, I might not look at it, but that's a lot of radiation that's getting put in the salivary glands. And I had a lot of patients that have had, not a lot, some patients, that permanent dry mouth. and that leads to cavities, difficulty eating. So it's not going to kill you, but it definitely affects your quality of life. And this is an issue with alphas that I think we need to be aware of as these things start getting closer to approval. I want to talk just a little bit about what to expect if we're going to go get this. And this is, again, how we do it here. There's guidelines about the type of people we want to do. And again, for the sake of time, I'm going to kind of go through this. But let's just say you were coming in to what we do. So we're getting referred. You'd come see us in our nuclear radiology. We'd come sit down. We do a very brief physical exam, get your history and do everything, and get the consent. And that's usually the day before. And so we'll have a chance for about 45 minutes or an hour, if it's really a long time, about 45 minutes or so usually, to kind of talk about everything, show the imaging, and usually the family's there, and we kind of talk about everything in terms of radiation safety, things to expect, how we're going to things progress. The next day they'll usually come in. The whole treatment takes about 2 to 3 hours. You're going to get an IV placed. We may put you on oral antiemetics. We don't typically do that. There's some things like with Lutathera we need to, but we find with this we don't really have to, but depending on your situation we may. We don't have to get IV hydration for most cases, just access to oral. You can eat. Actually, we are encouraging patients to have like a small meal beforehand. It helps a little bit with nausea. So there's not really anything you can do it. This is an example of our therapy room. Where we do this, it's all individualized. So the patients sit here in this chair, they're hooked up, and I'll show you a slide of this, but they have their own private bathroom, which is important because you're basically peeing out large amounts of radiation. So we need to have that access so that radiation safety can control that. This is these equipment here that we have a little vial that if you come and get a Pluvicto, this is a little plexiglass container that we can either administer using gravity through a line, which is actually really nice for us because we can evaluate for extravasation or these other issues like that. Or you can have a pump. We do both things. A lot of times our trials will have a specified pump administered a certain period of time. But both of these things can be administered fine. They're all approval. But the drug itself is it's going to come in a little green, painted, I don't know why, they all paint them green, they call it pig, and your drug's going to see in there. You're not going to see anything. It's just going to look like clear liquid that's going to be running through a tube. So we'll like hang saline, come down here, and then this is like a little contraption here, and then it's going to be a line going to the patient, and you can kind of see an arm right here. And then we just monitor the patients. They just sit there and we talk for 10 minutes, and that's pretty much it. The actual administration only takes about 10 minutes. Most people don't have any symptoms, no nausea or anything else like that. It's in and out. There's other therapies that take a little bit more time. Now, this is another thing I want to talk about, and I know we're kind of hitting for the time, and I'm very aware of that. But what we will often do, if it's feasible, is that after the therapies, the day after, 24 hours, we'll get a SPECT CT. And that's a reimbursable study here in the States, not here, down south in the States. And this is just a picture of our SPECT CT. It looks a lot like a PET CT. This is not usually like that. They're installing it, but I needed a picture at the time. But why we do that is, it is oh no, not again. Okay, so, okay, good. Oh, I'm going to show you some pictures. Can you move it forward? Keep moving. I'm going to skip these side effects. I want to show the imaging stuff. Keep going. Okay, keep going. Here. Okay, I want to give you an example. Well, can you go back a slide? So I just want to show some examples of why we do this, and actually it ties into radiation and other targeted therapies like radium chloride and stuff like that. So these patients, let's just assume they've all qualified appropriately for Pluvicto therapy. Let's go to the next slide. So this is can you hit it forward? Our guys should start moving. Okay, so this person, it looks very bleached out to me, but you can see here most of the disease centered in the cervical spine. And I could talk a long time about this, but anyway, we're doing Pluvicto. And then, oh man, it's working again. So what we've done SPECT CT afterwards. And so this is the baseline PET CT, and then this is after, I think, cycle 3 of Pluvicto, 4, and 5. And what you can see is actually this lesion here that wasn't there before and wasn't there on the PET CT. So this is worsening disease. All I'm doing is imaging the drug that we injected to treat. And you can see there's another guy that's lighting up here. Now, concurrently, we can also see that his PSA, it was going up, okay? And we say, you know what, we're doing Pluvicto, and we're still hitting most of the stuff in the cervical spine, and that's actually responding. But we have this other stuff that's getting worse. Well, you know what we did is I talked to my radiation oncology colleagues, like, well, let's target these lesions with radiation, continue on Pluvicto, so that he can continue that whole treatment, because we're trying to target everything. Now, this area had actually already been irradiated by external beam. They couldn't do any more radiation there, but we're doing it Pluvicto. And when they're able to target it, and this person was also having pain, the PSA started going down. So we're having therapy. Again, this is what we're seeing not in all our patients. 80%, everything's moving the right way, but there's about 20% of our patients where you start seeing an initial drop and then they start coming up. And what we're trying to do is get them to finish their therapy, but also target a lymph node or a bone that's moving forward with disease. And so this is another patient. It's going to be very similar. I want to show you some images here, except with, here's a PET. It's moving around or not. Okay, that's fine. There's some stuff here in the pelvis. I'm having a hard time with my buttons this afternoon. Oh, okay. There we go. So, boy, I think this thing's dying. You can see here, hopefully, on image 2, on the right side, and it's probably more so on the far right image, there's this lymph node here that's lighting up by the bone. We're able to identify that's the only thing that's getting worse. Everything else is going down. So again, we targeted that with radiation, and his PSA had been going up, and if you look, here we go, we got it. It had been starting down, and it was going up, and then we targeted it with radiation and started going down again. And he actually had good control. So that's how we are using this kind of multidisciplinary approach to treat patients. And the other thing I will say is, again, I'm not talking about clinical trials here, but what we do, there is a concept of radium chloride. And clinicians, I will say, even if you look at the outcomes of the Vision trial compared to Alsimca, which is the radium chloride, they're actually very similar. A lot of times patients and physicians want to be put on the PSMA because we can see it, right? But what I found is that a lot of times, and again, this is just clinical practice, not on trial, is that patients that progress on Pluvicto or short-term progression, it's almost always osseous disease. I don't know why it is, but it's rarely lymph nodes. I did show you an example of a lymph node. I'm not saying exclusively, but often it's bony disease. And what happens is they start getting pain. Like, I don't know how many people here have pain in their bones, but that is a common thing. And you can either say, well, if we can identify the site of pain, they can do external beam radiation. But more frequently what we're seeing is people will finish their Pluvicto and their PSA is still going up, and then we'll stick them on radium chloride for their osseous disease. And it is what happens almost uniformly is their PSA is not really changing. This is part of the problem with radium chloride. The PSA doesn't really follow it, but their symptomatic relief gets good. The question is, what do you do after Pluvicto, after radium chloride? I don't know, right? This is, again, we're just kicking the can down the road is the problem here, is that it's great if, I mean, not to be morbid, but say I have an 85-year-old gentleman that's coming in. I'm like, okay, look, I can give you a couple years of good quality of life. And maybe I can extend that out to have something else get into the way of life. But if you're 60, then you're like, well, I got 25 years. I got something else I have to deal with this. So this is where I think that ultimately where we're going is getting these radiotherapeutics on board, but we also need to get combinational therapies. We need to be looking at how early on in the disease process we're treating this. So we're still at the very beginning of this whole process here. And, you know, we are better situated than we were 10 years ago, but most definitely 10 years from now, we're going to be better situated. We're going to have a lot more handle on this stuff. So I know this went kind of fast in some areas, and my mouse doesn't work very well for me, and I hope you'll forgive me for that. But I appreciate your time. I appreciate you coming here. I learned a lot listening to my colleagues here in Canada talk about the various things. It's actually not that different for the most part. But if you have any questions, we could take them offline for the sake of time, or I'm happy to hang around. But anyway, thank you very much for coming out.
Thank you, Dr. Parent. What we'll do, kind of in the essence of time, any big questions about nuclear medicine, you've heard that all day long. Maybe a suggestion here is that we finish up. I think there's some refreshments waiting next door, and then we've also got, you're also invited to the Mars shot, which is downstairs where you're at all of the exhibits. So please, stay as long as you can, as long as your time will permit, and the doctors are around, us patients are around, and we're welcome to take any questions or have any discussions that you'd like. I want to say thank you, first of all, for coming out. I think it's important. I think everybody may have learned one or two things today. You're going to get because you attended and you gave us your email, you're going to get what do you call it? Survey. That's it. Thanks, Mike. In the email. It's been a long day. Please take a minute and fill those things out, because we do take your opinions and your suggestions into account for next year's event. And we do this every year. Next year it's scheduled to be in New Orleans, so if you want to come down and have some crawfish and etouffee, come on down. You'll now be a member of the club, and everybody will appreciate your own journey. So bring your stories along. I also would ask you to please pass on what you've learned. I think you've maybe learned the value of talking about this and talking to others in your community and in your family, and talk about this prostate cancer issue that we're all dealing with. I mean, it's number 2 diagnosed cancer in the United States, we know of, and in North America, actually. And I can spit out a lot of numbers, but it's growing. It's not going away. So we encourage everybody to get early screened, know what high-risk populations are, and actually have those discussions with your doctors and your family. So we really appreciate that. So again, thank you very much. We're next door for a couple of cocktails if you'd like, and then we're downstairs. So up to you. Thank you very much for your attendance.